is with me in my department for helping me out with this presentation. And with that, I will start with my topic, and the topic which has been given to me is barrier methods of contraception. And a few more topics I will be talking about. Basically, this is a postgraduate group, and we are talking about upcoming examinations, and that is why we are here. And the topic itself being barrier methods of contraception, it is one of the core topics. And what do I mean by core? Meaning of core is it is a must-know topic, basically. And when we say must-know, we are saying that it is one of the topic, though it is easy, it is considered as a primary bait. So being as an examiner for last so many years, I can share with you that this topic is as considered as a primary bait, meaning that your examiners will throw this bait to you to find out if you have read something or not. And when you have been given this topic of barrier, as in your practicals, we understand as an examiner that you have to be thorough with the topic. And being thorough means you have to have this topic at the, somebody is trying to, write on the screen.
Yes, ma'am.
So,
I'll clear that.
Yes, please clear that.
Yes.
And I would request all the participants to allow me to go ahead.
Yes,
Okay,
sure.
so this topic is about barriers. Am I able to?
Yes, ma'am.
Okay. Yes. So are you able to see? Yes.
Yes.
So we are talking of barrier methods, and as I've said, this is a must-know topic. And basically, I'm going to talk about the highlights, and I'm going to share with you what questions basically are put to you during your practical exams. In theory too, it can be part of our structured long answer question or sort of a short answer question also. Basically, we give emphasis for the practical examinations, and that is where we are going to talk to you. And of course, I would like this to be an interactive session. I have structured the presentation in the form of question answers. So we can chat on the chat box. And when I ask the questions, I want all of you as postgraduate to think about the answer before I give you the answer, and write on the chat box and test for yourself whether you're able to answer the question or not. And basically, I think that most of you must be knowing something or other about the barrier methods of contraception. So greetings from my college, which is the Jawaharlal Nehru Medical College in Wardha. And these are our learning objectives for today. We are going to talk about barrier contraceptives, types, efficacy, advantages, disadvantages, common pitfalls. We are going to talk about LARCs, that is the long-active reversible contraceptives, and non-oral hormonal, other types of non-oral hormonals. So these are our objectives for today. Before going into the whole topic, let me ask you a certain question about what are the criteria for ideal contraceptive. What do you say is an ideal contraceptive? An ideal contraceptive should be safe, effective, acceptable, inexpensive, reversible, simple to administer, independent of coitus, long-lasting enough to obviate any frequent administration, and should not require any medical supervision. So do we have any ideal contraceptive? Not at present, but your LARCs actually mimic a very close criteria for an ideal contraceptives, and we will go into that later. Now, first question is, what are barriers? Now, these barrier contraceptives prevent pregnancy and certain STDs. So that is a plus point, designed to prevent the passage of sperm into the uterine cavity during a sexual act, and it is one of the oldest methods in use. Now the question for you. Quickly type on the chat box, what are the types of barriers? Do you know the types of barriers? Yes, if you know, quickly type on the chat box. What are those? They are two types. It should be mechanical barriers, which physically prevent the sperm and egg meeting, and there are certain chemical barriers also called as spermicides. So these are the two types of barriers. Now, quickly enlist, you must all be knowing, and from the picture also you will get an idea what are the mechanical methods. So we should have on the tip of your tongue 5 mechanical methods, the male and female condoms, and then we have the diaphragm, we have the sponge, and we have the cervical caps. These are the mechanical ones. Quickly enlist the chemical ones. For the chemicals, we are talking of, foams, creams, gels, films, suppositories, and all of these are used along with some other type of a mechanical barrier like a female contraception and other devices. So basically, we do not want to use any chemical barrier alone. Okay, so that is the key point you should keep in mind. Now, talking of the male condom, it is a commonest and effective barrier, and it should be made up of latex and polyurethane to prevent pregnancy and STDs. So, if you want to prevent STDs, the material should be either latex or polyurethane. Now, quickly, another question for you. Name one country where condom is the only barrier method ever known and used. Does anybody know about it? You can chat on the chat box.
We have to
Anyone
wait
who knows?
1 or 2
One
minutes.
country. So,
We have to
yes,
wait for 1 or 2 minutes
Ina?
from that. India. Someone has answered India. Africa.
It's not India. It's not India. It
Pakistan.
is Ethiopia. And this is the country where condom is the only barrier method used. Okay. Quick question again. What are the slang names for condom? Anybody knows the slang names? The slang names for condoms? Yes.
This
It's
one.
called as a rubber or the sheath or the skin. Okay,
Nero.
so these are the slang names you may be asked. So these are the questions actually the examiners are commonly they enjoy very well to pose to you because they think that you may not know. Okay, so these are also called as skin and also called as a sheath. What is the mechanism of action? Very simple. It's a barrier to avoid the bodily fluids and semen and blood to be shared, as a result of which the pregnancy is avoided, as well as certain reproductive tract infections like gonorrhea, like we're talking about chlamydia, trachomatis. So these are all, and of course HIV, HPV, and herpes. These infections are also. This is called as the double plus effect of the barriers, which is very, very important, especially of the male condom. And now next question to you quickly. What is the meaning of Nirod? Anybody? Quickly chat on the chat box. Nirod is freely available, free of cost. Government of India is providing the Nirod. But what is the meaning of it? Meaning of Nirod is nothing but it is a Sanskrit word meaning prevention. So the only meaning of Nirod is prevention. Now let's go on to the next one. What are the types? What is the make? What are the sizes? And what are the dimensions of the condom? Basically, it is all the condoms mostly will have a reservoir tip or a teeth end to make it easier to accommodate the ejaculate. Various sizes are there, and we call it snug fit or large fit depending on the size of the phallus, and it is usually from experience that the person will know which size will fit. If it is too tight, then there is a chance of breakage. Various widths are available from 49 millimeters to 56 millimeters, and lengths from 45 to 60 millimeters. So basically, when you are reading something, just look at the highlights, what to remember. And of course, variety of surfaces are available to stimulate the partner who is using it. And of course, condoms are usually supplied with a lubricant, so there is no need of using another lubricant to it. Flavored condoms are also available. Mostly the condoms are made up of latex, but polyurethane and lambskin. Remember, lambskin is the one which is a natural condom. You may be asked the question, which is the natural material used? It is the lambskin. And if we talk of effectiveness, effectiveness is always measured in the case of a perfect use or a typical use. When you say a perfect use, that means all the norms which have been advised are being followed. Whereas when you talk of a typical use, it means that routine use, whatever they are doing routinely, that is the typical use. So when you define any effectiveness of a contraception, your answer should be like this. In case of a perfect use, the pregnancy rates are 2 to 3 per 100 women years. So use the unit properly. And if you're talking of a typical use, then it may be 14 to 25 depending on how they are using the condom. Okay, so that is how you're going to answer when you're asked about effectiveness of any condom. Somebody is writing on the screen, please don't do that. Now, advantages. You should have the advantages of simple contraceptives like a barrier at the tip of your tongue. It is easily available, it is safe, inexpensive, easy to use, no side effects like a hormonal contraceptive. It is light, compact, disposable, provides protection against STD. This is very, very important to note. And of course, can be stopped at any time. Fertility returns immediately, very shortly, very easy to find. No need of a healthcare provider to actually fit it out for you. Men of any age can use it. Animals, a man to take the responsibility of preventing a pregnancy as well as STD. And very important, when there is infrequent sex, when the partners are not meeting frequently or regularly, condom is considered as one of the best contraceptive and the contraceptive of choice. So all these advantages has to be at the tip of your tongue. Disadvantages like slippage, tearing, interferes with sexual pleasure, high failure rate. If in the typical use, there is a high failure rate, and you have women have to rely on the man's cooperation, and sometimes condoms are connected with immoral sex. That's why people don't want to use it. People may be embarrassed to use it. Disposal may be a problem, itching, allergy. And you should remember that if they are stored for too long or stored not properly stored, then they may be a weakening and the high failure rate. So these are the disadvantages. Now, anybody, what is the next question for you? 5 most common mistakes during use of condom. So anybody who can answer this? The 5 most common mistakes, you can chat on the chat box. One, first of all, not having a condom when needed. Another is starting the intercourse without the wearing the condom on the phallus. This is the most common mistake. And of course, tearing the condom packet with a fingernail, another mistake. And not holding the rim of the condom when withdrawing, and forgetting to use the condom altogether. So these are the common mistakes. Next question which can be put to you by the examiner: what important messages can you give to a condom user when you're counseling for the use? Now, these important messages could be not to wear 2 condoms at a time. So sometimes there's a misconception that if you wear 2 condoms, maybe there's a more protection. Basically, you will increase the chance of tearing, and there is a chance of failure, more chances of failure if 2 condoms are worn at a time. It has to be thrown away after each sexual act. That also we need to tell some of the rural, I am from a rural institute, and we have to tell them that it has to be thrown. It cannot be reused. Then whether a male and the female condom can be worn at the same time? No, it should not be done. Otherwise, there is a problem in the use of both, and maybe you'll have a high failure rate. And of course, the condom has to be used from start to finish. So you must be noting that for each question, I'm having at least 5 answers on the tip of the tongue. So that is how you learn to, give the answer when your examiner is putting. So now next question: with which lubricant to use with condom? Do you use a lubricant or not? Yes, if you think that because of the age, the intercourse is a dry intercourse, then you may try to use, you may advise the user to use the lubricant. But which lubricant to use? Anybody? Just be alert, and you can use the chat box to type it out. Which lubricant to use? It has to be a water-based lubricant, and the best one is a KY jelly, which you may advise your user. And why not oil based? Why you're not going to ask your user to use a oil based? Sometimes your clients may try to use some creams, vegetable oil, whatever is available in the home, they will try to use it. But you have to tell them not to use an oil based lubricant, because it's going to cause breakage of the condoms. So basically only the water based jelly has to be used. Now, how to use steps? New condom has to be used before the physical contact. It has to be placed. It has to be enrolled up to the base of the phallus, and immediately after ejaculation, holding the rim of the condom, it has to be withdrawn and disposed of safely. Remember, whatever you say, the next question from the examiner will come from the last word you have spoken. So if you say that dispose the condom safely, quickly the question will be asked to you, how to dispose the condom. Okay, so how to dispose? Basically, you have to advise the user to use the packaging. The packaging already is available. So that packaging which they have torn, that condom has to be put in that package itself and thrown in the dustbin. Most of the user will not even know whether it has to be thrown in the. So you have to ask them to throw it properly wrapped in the packaging with which it has come. And of course, keep in away from the reach of children. Sometimes we have seen that them choking on that. So if the parents are not careful, you may have some emergency on the hand. Now, again, a very, very common question which has been asked in case of barrier, especially the male condom, is non-contraceptive use. Anybody who can quickly unmute and tell me what is a non-contraceptive best use of condom which prevents. Yes.
Prevention of
So,
STDs.
any other non-contraceptive use? It is as a uterine balloon tamponade. So how many of you know this and have used this for an emergency? So this is to give a uterine balloon tamponade for PPH management. Very, very effective if used properly. Of course, everybody knows that it covers the UHG probe in transvaginal scan, prevents STDs. You should also remember that it can be used as a condom catheter. So we usually forget because we are dealing with females, so we don't remember that it is also used to wean off people from the regular Foley's catheter. And because of the prolonged use of Foley's catheter, there may be a problem during micturations, and that is how the weaning off is done by use of a condom catheter. And of course, during a vaginoplasty to make molds, if you don't have the proper dental molds, we may use the condom to wrap around the gauze pieces. We have done it many times, and we can very nicely make molds out of condom. So these are the very beautiful non-contraceptive uses of condoms. Now, apart from that, because it is so nicely made, and of course, in the treatment of infertility also, condoms are used, and I will tell you how and why it is so effective in cases of patients with infertility. Of course, the next question would be, what is the mechanism by which condoms are beneficial in infertility cases? So the answer to that is, wearing a condom prevents the sperms to be deposited in the vagina and can't reach the cervical mucus, and reduces the anti-sperm antibodies, which destroys the sperm. So in case of females who are having high level of anti-sperm antibodies, then they are asked to, the male partner is asked to use the condoms at least for 3 months, and that is how it helps in infertility treatment as well. Now, this is a quite an uncommon question, which many of the students will not know. What is the rate of breakage and the rate of slippage of a condom in a typical user? Okay, so the rate of breakage and rate of slippage is around 0.4 to 2.3% breakage, and 0.6 to 1.3% breakage, slippage. So in 100 users, you may have 1 or 2 who will have the breakage and the slippage. And even if there is no breakage and slippage, 1 to 3% of women will test positive for semen residue after intercourse with a condom. So that means even if they are using the condom, there is still a possibility of the semen being present in the vagina. So does that mean that the condom is not useful in these cases when there is a breakage or slippage? What do you think? So to answer that question, one study was done and it has been found that semen exposure from broken condom was about half that of the unprotected intercourse and 1/5 of the unprotected intercourse in case of slip condoms. That means even if there is slippage, even if there is breakage, so you still have a 50% benefit. The user will still have that benefit, so 50% less chances of pregnancy will be there if even if there is a breakage or a slippage. So this is a very tricky question which can be put to you. Now quick more questions. What is double bagging? Anybody? So double bagging I have already described. It is wearing 2 condoms at one time, and failure it is high because of friction of rubber on rubber. Next question. What is condom sabotage? Anybody? These are certain tricky questions which may be put to you. Now, condom sabotage is actually with the motive of child having a child against the partner's wishes. And this has been observed in Nigeria when clients sabotage the condoms because they are forced to using a condom. So they want to, somebody is still writing on the screen. Please don't do that. Okay, don't write on the screen, please. So this is condom sabotage when fine needles are used to create pinholes, and it has been seen in Nigeria and it has been reported too. Please don't write on the screen. What are the collection condoms? Anybody who knows about collection condoms? Collection condoms are used again in when we want to test the semen sample, and these are made up of silicone and polyurethane instead of latex. Why do we not use latex? Because latex is harmful to the sperms and we may not able to measure correctly the sperm count. Semen analysis may not be done, and it is preferred in men who do not want to give the semen sample by masturbation. In some religions, masturbation is prohibited, so you will not have these patients who are able to give the semen sample for examination. So that is where the collection condoms are used, and studies have shown that samples obtained by masturbation, instead of that, if you compare from the collection condoms, you may have a better sperm motility, better percentage of sperms, and more normal morphology. For this reason, they are believed to give more accurate results, and also chances of pregnancy are more in case of intracervical and intrauterine insemination if you use sample from the collection condom. So I think this is a new knowledge I am giving you. So talking about collection condoms, which you should be able to answer. Now again, what is condom therapy? Condom therapy again is for your infertility patients where you would like to treat the anti-sperm antibodies. So these words, they will try to trick you the examiners will try to trick you by using certain words. The answer you may be knowing, but these words are what the examiners will try to use. Now, another question. How is the condom tested before packaging it? How is it tested? Does anybody know? Yes, every latex condom is tested for holes, open holes with the use of an electric current. So that's a technology which is used. And in addition, a portion of each batch of condoms is subjected to water. Not all the condoms, but you are having a batch, and from then few of them will be tested for water leak and air bus testing. Now, few more facts. Quickly, I will tell you about condoms, and those are that condoms are also used to protect scientific samples from the environment because it is a waterproof material. So they have been used in scientific research and waterproofing of microphones for underwater recording. Probably you may not be knowing this. Another non-contraceptive benefit, and you may have heard about condoms being used to smuggle certain things like cocaine, heroin, drugs. And in prisons, these condoms are filled with drugs, and either they are swallowed or inserted in the rectum, and that is how they would like to escape the police. And these are certain other uses. Now, newer material for condoms. These are the two new materials which are being used and tested in research. One is 8010 resin, another is polyisoprene. As I've already asked you, biological condom. Biological condom is made from lambskin. Anybody has heard of anti-rape condom? Anti-rape condom is again under research. It causes pain if there is penetration. And of course, textured condom is to improve the pleasure during the intercourse. And spermicidal condom is again another condom which is it has a spermicidal agent along with the routine condom, but research has not proven that it is better than the routine condom, so it is not in vogue, it is not in use. But you should all be knowing about the various type of condoms. So now that was all about the male condom, and the next question will of course be asked to you, what about the female condom? Can the female again use condom? Yes, they can. This has come into vogue as an alternative to male condom. Why? Because men do not want to use anything. So female should have the choice. She should have in her own hands to protect her against pregnancy. It is made up of polyurethane.
Hello, ma'am. Ma'am, can you hear me?
It is already used by the woman. Somebody wants to speak something?
No, ma'am. You can.
Okay. Of female. Okay. Now, problem of the female. Let me water. You should also know that the female condom covers part of the external genitalia. So these are certain problems. Because it is visible to the male, it may not be acceptable. Okay. And you should also note that there are various generations. Somebody's legs are visible, please close it. Okay. And so इसी पाव दिख रहे हैं बढ़िया से. Galaxy A50. Close your camera. So FC1 and FC2, these are the two generations of female condoms which you should know about. The first generation was made of polyurethane, second generation was made of nitrile. So these are the certain questions that may be put to you. And a recent version of the female condoms is also made of natural latex. Effectiveness, 5%. Inconsistent or incorrect use may even have a very high failure rate up to 21%. Now, there is one female condom which you should know about. It is called as the woman's condom. That's a brand name for it. It is a polyurethane pouch. So routinely, it is a full, sort of like a male condom, open condom is available. But in the woman's condom, it is available as a capsule. Just like the pastry which we advise to our patient, it is available as a capsule, and that capsule, it is inserted in the vagina. It quickly dissolves and releases the condom, and the patient can very well use it very nicely. It has been being used in the European countries, not available in India, of course, but should know about what is a woman's condom. Benefits: the woman has the choice, she is independent, it can be inserted hours before the intercourse. There is no need for the penis to be erect, does not require immediate withdrawal, it is not tight or constricting, and it is safe, does not affect the hormonal level. Now, certain disadvantages are cost, availability, not available. Maybe many of the students may not have seen the female condom also. It is usually seen only during the time of examination by most of the students. Not available. Irritation to the genital area, maybe they may slip and it reduces. And sometimes the crackling sound is also there during intercourse, so may not be liked by women to wear it. Now, the third barrier which you should know about is the diaphragm. Diaphragm, another name for diaphragm is, it's also known as the Dutch cap. It came from Germany in 1882. Now, it is sort of a cup made up of rubber, plastic, or latex. First time when the fitting is done, it has to be done by a physician. Depending on the type of vagina, the size of the cup will be chosen, and the woman will be told about its use and fitted by the physician. So that is a disadvantage, because the woman has to go and get herself fitted, of course. But once the fitting is very well done, she can use the same diaphragm again and again by washing it and storing it well. It can be inserted quite a few 18 hours prior to the intercourse, and but it has to be left inside the vagina for more than 24 hours. Not less than 6 hours, it should be kept inside, and failure rate is around 6 to 12 HWI. HWI is 100 per 100 women years. So, guidelines for insertion, she has to check for any holes. Always a spermicide has to be used along with the Dutch cap. It has to be folded into half, fitted over the cervix, and reapply the spermicide if more than 6 hours are over. Must remain in the vagina for 6 to 8 hours after the intercourse, and has to be washed with soap and water, warm water after the use. So, diaphragm again was very well used and accepted in European countries. It is still being used, but in India, I haven't seen many people, many women using it. Advantages is can be carried, can be inserted hours before the intercourse, cannot be felt by either of the partners, and thus it is considered as an advantage, and it does not interfere with the women's hormones. So that is important. But sometimes the disadvantage is why the woman is not using it. She doesn't like. There may be trouble mastering the removal and the insertion. It may get dislodged, and it has a high failure rate. Does not protect against STDs. That is a main disadvantage of a diaphragm, and that is why we are not, as a provider, we are not advising when we are talking about protection against STDs. The diaphragm is not advised. Now, similar device to a diaphragm is a vaginal sponge, and market name usually is asked by the examiner. Market name for the sponge is Today. Tell me one syndrome with which this Today is associated. I'm giving you a few seconds to think about it. That is the toxic shock syndrome. So it is so comfortable to wear, and the lady is not even aware that she has inserted it. No, so there she has no problem, so she forgets to remove it, and that is why that is where the infection may set in, and the patient, the staphylococcus associated infection, which causes toxic shock syndrome. Very favorite question of examiners. This sponge is made up of polyurethane foam. So it is very soft material as compared to the Dutch cap, and it is far effective as compared to the diaphragm also. And even nullipara women can, use the sponge. So these are key highlights which you should remember about the sponge. And most important one is its association with TSS, which is the toxic shock syndrome. Now, last but not the least, we will talk about the spermicides. And when we talk about spermicide, the main important thing to remember is it should not be used alone. So, no user will use it alone, nor the provider will ask it to be used alone. It kills the sperm, of course, as it is a surface active agent which inhibits the oxygen uptake. It's available in different forms like a jelly, even film is available, even a sort of a foam is available, suppositories are available. But if it is used alone, the effectivity is low. 76% is considered as a low effectivity, which means that the failure rate is around 24 to 25%, and hence it should always be used with another device or another, something like a condom or a sponge or a Dutch cap. And the active ingredient is usually asked, and that is nonoxynol 9. Even octoxynol 9 is one of the ingredient, and both of these should be known to the postgraduates who are facing the viva. So that is all about barriers, and I will stop here for the barriers. If there are any questions regarding barrier, I can take them now, or we can wait and go ahead and talk about injectables. So I'm giving you a few seconds if you want to ask anything about the barriers.
Ma'am, can I ask the question? Diaphragm always
Yes.
inserted by gynecologist. Is diaphragm always inserted by the gynecologist?
For me, is that the question? So initial fitting should be done by the gynecologist or a healthcare worker who is trained. So not even if a healthcare worker. So in European countries, it is not always the gynecologist. So we should think globally, act locally. That is the mantra. So when you answer that not always a gynecologist, but a trained healthcare worker, the initial fitting. Afterwards, once the fitting is correct, when she finds comfortable, she uses it on her own. Any other question?
Ma'am, diaphragm, why we can't use less than 6 hours?
Because there is a chance that there is a leakage of the sperm, and it may travel up and may enter the uterine cavity, cervical canal. So not less than 6 hours to be given for actual the sperms to die down. Before that, if you remove it, then you will find active sperms and they can travel into the uterus. So high failure rate is there if less than 6 hours is there.
Barrier contraception for how many days to treat anti-sperm antibody?
So usually we advise for 3 months treatment. So that is the time given for infertility condom therapy. That's the 3 months of therapy is required. But let me tell you that studies have shown that the pregnancy rate is not higher. There is no proven benefit. Though it has been tried, researchers has shown that there is no proven benefit. So even if you use the condom, maybe the pregnancy rate has not increased that much as expected.
Ma'am, is nonoxynol 9 is teratogenic if the condom breaks or
So
failure occurs?
see, now the answer to the question is that not many studies have been carried out in it. Okay, but still, if she conceives, nonoxynol 9 is not considered as a teratogenic agent. Now, to remember how to answer this also, because you have to remember there is something called as the teratogenic cycle. Okay, so initial few days of after fertilization, no teratogenic agent can act on the fertilized zygote. So no chemical exposure, any exposure cannot be considered as a teratogenic in the initial 3-4 days. So basically, you need to answer that there is a teratogenic cycle which is followed, and usually it is after 4-5 days of, and then up to 8 weeks. That is what is the most teratogenic effect of any drug is there.
Ma'am, pore size of condoms.
So there are various sizes. Okay, as I have said, you need to remember two, which is the snug fit and the large fit. In between, you have two more sizes, starting from 45 millimeters to 60 millimeters, and that is how various sizes are available.
Why initial 3-4 days no teratogenicity?
That I have already answered. Okay.
Yes, ma'am.
The teratogenicity starts only after 4 to 5 days. Before that, the fertilized ovum, no teratogenic effect is there on the fertilized ovum. The cells are impermeable to any drugs.
Yes, ma'am. Ma'am, can you explain please condom sabotage? There are so many questions for the condom sabotage.
Okay, condom sabotage is regarding, this term actually has come from Nigeria, where there a lot of prostitutes and have reported the condom sabotage, because once we talk of HIV and we talk of the advantages of using condom, so basically the sex worker will ask the client to use the condom, and it is known that by using the condom the pleasure reduces. The client will try to sabotage that by creating pinholes into the condom. So they will use the condom, but they will still cause the pregnancy in the sex worker, and that is called as condom sabotage. It is well known, and the term has come from Nigeria.
Okay, ma'am. Ma'am, we can go ahead.
So should we move ahead with the
Yes.
next? And the next is about non-oral hormonal. Basically, I'm going to talk about long-active reversible contraceptives, also called as LARC, considered as an important topic, and it is nice to know topic. Must know also in case of injectable, but otherwise a nice to know topic, considered as a secondary bid by the examiner. So if you're doing well with the barriers, they will give you another sort of, the higher level, and that is what is the long acting reversible. Can also come as a short answer question or part of a structured LAQ. Now, the first question which comes to you in your mind, what is a long-acting reversible contraceptive? How do you define it? When you want to talk about long-active, it means that the administration requires less than once per cycle. So in 1 month, only the administration is only once. So one per cycle or per month, that is called as a long-acting, and it provides effective contraception for an extended period of time without requiring a user action. When you say the user, it is the person who is using the contraception. And of course, you have another word, which is the provider who provides the contraception. So no user action is required for an extended period of time, like an oral pill or like a barrier where, the user has to use it, quite frequently. And when we say reversible, it means that the efficacy, somebody is still writing on the screen, please don't do it. Most effective reversible method of contraception, because the efficacy is not reliable or reliant on the patient compliance. Like in oral pill, if the patient is not compliant, the failure rate is high, but not so in case of a long acting. Once you have given the injectable, then no need to take for the patient compliance. So that is what is called as a LARC. Now, question for you. Can you enlist certain LARC? The pictures are already given there. So you can test yourself if you know LARCs. Now, these LARCs are the implants, then certain devices. You have the injectables and your intrauterine systems, and query the patches and ring. Why I have written query? Because they are not considered so much as the LARCs. These are the non-oral hormonals. But mostly your implants and injectables may be considered as LARC because they are long acting and they are also reversible. Okay. Now, so do we know certain market names of LARC? One of the devices which is considered as LARC is Mirena, your Paragard. Then in case of implants, we have Nexplanon, Implanon, NXT, then Norplant, of course, and Jedil, which is internationally known, very commonly used nowadays is Jedil. Instead of the Norplant, Jedil is most commonly used. Now, some short acting method, because once you insert the implant, it is acting for a prolonged period of time, like 3 years, 5 years, but certain injectables have to be repeated every 3 months, so they are considered as a shorter acting sort of LARCs. So these are the progesterone only injectables and certain combined injectables also, which are commonly in use. So we will talk in detail about implants and injectables, because if you talk too much, then the students are not able to retain. So I'll talk about implants and injectables mostly. So let us remember certain quick facts. So if you talk of any contraceptive or any subject matter for that subject or topic, you have to remember certain quick facts. Quick facts are that is considered as a most effective method because it is efficacy is more than 99%. It is considered as safest because side effects of estrogen are not there. Contraindications are very rare for LARCs. High patient satisfaction 80% versus 50%. High continuation rate again 86% versus 55%. Long protection for almost for the maximum protection given is up to 12 years. So if the LARC is used once, it can give protection up to 12 years. I'm using the word up to that you should understand. Rapid return of fertility is there once the LARC is removed. Most cost effective because once the cost, see, initial cost is high. Remember that the initial cost is high, but because it is used for a prolonged duration of time, the cost effectivity is there, and that's why it is considered as a very, in European countries. See, in India, many of the things are provided free. Okay, like the copper devices are also provided free, but if you go into European countries, you will come to know, or even Americas, you will come to know. I have gone to Netherlands, I've gone to Ireland, and we'll come to know how much cost it is there for contraception. So if you're talking of adolescents and the use of LARC, they are considered very cost effective, and though they are considered very good for teens, one quick fact to remember, it is not actually very nicely used by teens, and that is where they are trying to promote that it should be used by as a good contraceptive by adolescents. So if you're talking of adolescent clinics, the most effective contraception is LARC, and that is why that is what most of the organizations working for contraception are promoting. Now, if you want to talk about effectiveness, remember effectiveness is always talked about as a perfect use and a typical use. In my talk on barriers also I have said this. Now, what is perfect use? When complete adherence to protocols is there, schedules is there. And what is typical use? Whatever real world conditions are there, that is called as a typical use. So if you talk about LARC, as there is no user action required, once it is inserted, so for LARC, it is true that the perfect use failure rate is similar as the typical use failure rate. That answer has to be given to the examiner. The typical use and perfect use completely coincide with each other, and the failure is very low, less than 1%. So just like sterilization, we say the failure rate is hardly 0.1 to 0.6. So similarly, LARC failure rates are also quite low, less than 0.5, and that is where it is considered to be highly effective sort of contraception. And next question will come to you, what is the continuation rate? Do they continue beyond 1 year of use also? So if you talk of a LARC, which is a long acting, and if you consider with short acting methods like the shots or the pills or the rings or the patches, so long acting methods have 86% continuation rate in the next year as compared to the non-long acting. So you compare the both, it is 86% versus a 55%, which is considered as a very good continuation rate in the next year. So LARCs are considered to be very effective, good continuation rate, and that is why it has been preferred. And of course, they are women-centered. Women are having the choice. They don't have to be dependent on the men for contraception. Now, next question, again a high order thinking question, which we call as a HOT question, is how do LARCs compare with other methods of contraception like the pills, like the barriers? So how do they compare with it? If you compare over a long term, LARC methods are 20 times more effective to either the pill, either the patch or the ring. and that is why it is considered as one of the very good reversible method. See, you should understand that sterilization is a permanent method. It is having a very good efficacy, but it is permanent method. So if you consider a reversible method with a good efficacy, and that is where we talk about an LARC. Now, next question is, why is it so much beneficial? Why is it considered as so much efficacious? Very simple answer to that is, yesterday you had a talk on oral pills by Geeta Balsarkar madam, and she must have told to you what are the side effects and complication associated with estrogen. That is one thing. So here in LARC, lot of progesterones are there. Now in LARC, because it's an injectable, it avoids the first pass metabolism through the liver. That is its benefit. Secondly, gastrointestinal interference with absorption is not there. Okay, so what does it result into? Lower doses. Lower doses means lower side effects and lower risk. And all your benefits of LARCs are based on this. So you should have it on the tip of your tongue. Hepatic first pass metabolism is avoided, lower dose, less side effects in case of an LARC. But even if there are certain side effects which may not be acceptable, or which may require more interaction with providers, more counseling is required, certain side effects are still there because of the progesterone component. Most of you should learn by heart what are the progesterone side effects of contraception. One of the side effects which is troublesome, which is worrisome, is irregular bleeding pattern. The patient is not able to tell which is her menses, why she is bleeding so irregularly. So the bleeding pattern changes there, and that is troublesome, and that is why she comes to you again and again, why I am not bleeding or why I am bleeding. Okay, so that type of little bit of spotting or withdrawal, and she will need assurance that she is not pregnant. So that is why sometimes it is troublesome, but with counseling it will be acceptable. Some women will have amenorrhea for a long period of time, and that also it's troublesome for some women. Now, because of the progesterone, emotional lability is seen, headaches. Now, another very unacceptable type of side effect is weight gain. And how much weight gain? Around 1 to 3 kg of weight gain has been seen with the use of progesterones, which can be controlled if you counsel about good nutrition, regular exercise. So all lifestyle modification, if suggested, this weight gain also can be circumvented, and you can counsel the patient to adhere to the LARC. Headache, some patient may have migraine, and acne may be seen, but less so as compared to and sometimes a decreased libido may be seen. Some women have and very important thing to remember is that the efficacy is very high. So efficacy is as high as, very less failure rate as low as 0.1%. That is 1 per 1,000. But if there is a pregnancy, then ectopic pregnancy is more common. Uterine pregnancy is less, but if there is a pregnancy, this is a very let me have some water. So the pregnancy rates are low, but if there is a pregnancy, then chances of ectopics are high as 1 in 20. So if an LARC pregnancy, then you should always search for an ectopic pregnancy. Okay. Now with that, we move on to the descriptions of certain LARCs, and I will just go into a little bit of details of the implants, which though are not very commonly used in India as such, they are used in elite societies because of the cost is one thing, okay, and availability is another. Indian markets are not so much prone to have implants, but if you go into internationally, you will find that implants are more used, more even as compared to, your in India, intrauterine devices are commonly available. That's why implants are not used. But if you go to foreign countries where women are insured, health insurance is there, that is where the contraceptive implants can come into vogue. And if you talk of implants, quickly it should come into your mind that the first implant was Norplant. And if you go through your books, initially 6 rods used to be used. Now the use has been discarded. When I was a resident, we used to talk more about Norplant, but now Norplant is no more in use, but still you have to know about it. What is in use is Jedil, which is having 2 rods. It contains levonorgestrel, effective for 5 years. Another thing which is in use is one rod called as Implanon. The progesterone which is used is etonogestrel, which is effective for 3 years. So again, the highlights have to be remembered: 6 rods, 2 rods, 1 rod, your levonorgestrel and etonogestrel. Now you should also know about what is a biodegradable type of implant. So you insert it, but you don't have to remove it because it gets absorbed and does not require any removal, effective for 2 years. Now if you are posed a question of what are the types of implants are divided on the content. So if you are talking of levonorgestrel, the answer is Norplant, Jaden and Sino implant. Sino, as the name suggests, comes from China. And etonogestrel, there are 2 varieties, Implanon and Nexplanon. These are the 2 types of the implants. So one by one, a little bit of detail I'll tell you about Norplant. This Norplant is a first generation of the implant. It is a polymer membrane permeation controlled delivery system. So it is the tubing is made up of silicone elastomer, and depending on the thickness of the wall, the rate of the drug releases. So you can see in the diagram, the levonorgestrel crystals are there, thin walled silicone elastomer is there, the adhesive is there, and you can see how in a fan shaped manner it can be inserted into the upper arm. Consists of 6 flexible rods containing levonorgestrel 36 milligram. So that is a total, and each capsule is 34 millimeters. So you can see it's quite long, 3.4 centimeters. Diameter is 2.4 millimeters. Effective for 5 years. So prolonged period of time. Once insertion is done, it is effective for 5 years. But because so many rods are there, the use is now discarded. And now what is in vogue is Jedel. You can see in the diagram how Jedel looks, and there is an inserter there, and it has to be there are 2 rods, and each rod is 2.5 millimeter is diameter. Now you can see that the length has been shortened, 43 millimeters. Each has a drug releasing core encased in a tube, and that tube is made up of silicone. Okay, in which 50% of the weight is of levonorgestrel, that is 75 milligram, and 50% is of the 50% is of the silicone elastomer which is used. Effectivity is comparable to Norplant, though only 2 rods are used. Here also the effectivity is 5 years. So effectivity of Norplant and Jedel is comparable. Now for the insertion, do you require an incision when you insert a Jedel? No, it is not required. Why? You can see here there is a needle with a hub, and there is a bevel tip. With that bevel tip, and there is a plunger. The plunger itself will push the implant into the under the skin. Okay, so there is no need to give any incision. Local is given, local anesthesia, and usually it is inserted in the upper arm, and the 2 rods are placed in a V shape with the opening towards the shoulder. So the open part of the V is towards the shoulder. Now, rate of release of levonorgestrel for Jedel is 80 microgram per day in the first month. So first month will have a high release rate. quickly the action of levonorgestrel will be there, and after that a maintenance dose for the next 9 months 50 microgram, and later on after 9 months for the next 4 years the release of levonorgestrel will be 25 to 30 microgram per day. So initial high dose of progesterone followed by a decrease in sustainable dose. Please do not write on the screen. I am able to see somebody is scratching the screen. Please don't do that. So I think you can disable that. Minal, somebody is trying to scratch the screen.
I can clear that, but
No?
I can't disable that.
You can. Okay, let's see. Okay, now that is the placement in the upper arm. Next, very important implant is implanon. It is a single rod. It is flexible as compared to, so you should remember the differences. Okay, it is flexible. It releases etonogestrel. Previous one was what? You remember that? This one is etonogestrel. Effectivity is for 3 years. Previous one was for 5 years. So keep on remembering, repeating, revising. That is how you remember. Okay. Measures 4 centimeters, so little bit smaller. Diameter also has reduced, so it is now 2 mm. So you can see how they are trying to improve on their previous devices. So implanon is only a single rod. It releases initially at a rate of 60 to 70 microgram, which reduces to 45 microgram, and finally it comes to 25 to 30 microgram per day. So the total progesterone content is different. It releases per day around 25 to 30 microgram of etonogestrel, and effectivity is for 3 years. Now the next implant, which is again very good, is Nexplanon. Now Amplanon and Nexplanon, remember only the difference between the two. Okay, so if you want to reproduce what you learn, you need to always fix your mind and focus on the differences between the two. Now if you look into implanon and Nexplanon, there is only one difference, and this difference is addition of barium sulfate to make Nexplanon radio opaque. So radio opacity is the highlight of Nexplanon. That means it is visible on X-ray, CT, MRI, and that is the difference. Otherwise, it is very well comparable to implanon. That's how you remember. Okay. Now, other implants which are highlights are another implant which is called as an LNG rod. So maximum amount of LNG is present in the LNG rod, and which is 150 milligram. Okay, and if you are asked a question about minimal duration of use which implant is having, that is the Uniplant. It is effective only for 1 year. Okay, so this implant, if somebody wants to use only for 1 year and they want to use an implant, that is the Uniplant, and it contains another newer type of progesterone, which is Nomogestrel, and it contains 38 milligram, releases 100 microgram per day. So my advice to all the participants is, when you're learning, learn the highlights, learn the differences, and try to remember only the differences, and that is how you are able to answer the question posed to you by the examiner. So from my side, that is all about implants, and we move on to the next, which is injectables. Again, very important topic, very favorite of the examiners, because now even the government of India is providing free DMPA. So, and it has been come into the new programs from the government of India. Health and Family Welfare Ministry itself is promoting injectables. So that is why it is very important for the students to learn about injectables. Now, if you talk about injectables, the first questions which will be posed to you, what are the types? Now, if you talk of types, there are two main varieties. One is the progesterone only, and another is the combined. Okay, and if you talk of the progesterone only, which comes into your mind, one is DMPA, another is NET-N. Okay, Now DMPA, now remember the differences between the two. DMPA, how much? 150 milligram. Net-N, how much? 200 milligram. Now DMPA is a suspension. So remember these things, because when you want to inject it, it has injected differently because it's a suspension. And this one is oil based. DMP has to be repeated every 3 monthly, whereas Net-N has to be repeated every 2 monthly. My question to you is, how frequently do you administer the combined one? Anybody to answer? Now, to answer that, you should know that the combined one there are two varieties which are in common use. One is the cyclophem. The cyclophem contains DMPA 25 and estradiol cypionate 5, whereas the mesigna contains Net-N 50 and estradiol valerate 5. And each has to be repeated monthly. So remember, when there is a combined, it has to be, you cannot use for a prolonged period of time. And that's why, how to remember? Combined is always monthly, Net-N is 2 monthly, and DMP is 3 monthly. That is how you remember and train your mind to remember. Another HOT question is, what are the new formulations of Depo-Provera? New formulations are Depo Sub-Q Provera 104 and Uniject. What are the advantages of the sub-Q? From the word itself, you can remember. Sub-Q means subcutaneous. Okay, it is the subcutaneous. It provides 30% lower dose as compared to your routine Depo-Provera, which is 150, and this one is 104. So 30% lower dose of progesterone, rapid onset of action, and though the dose is lower, the effectiveness is equal, same length of protection, and that is every 3 monthly. And of course, there is a potential for home use and self injection. So no need to go to the provider to get it injected, and it can be used subcutaneously at home. Now, similarly, if you look at this another injectable, which is called as Uniject. If you look at on the right hand side, there are various images I have put of Uniject, and you can see then in the lower image how user friendly it is. It is containing a single dose and single package. You can see very nice vials are available. These are pre-filled syringes, pre-filled. They are sterile and non-reusable. They are having a very short needle for subcutaneous injection and does not require a provider at all to inject, and very compact and easy to use. And that's why it has a huge potential for home run. That means can be used by the user at home itself. No need to go to the provider, and that is the beauty of the new injectable, which is called as a Uniject. So these two, remember, they are very good, and they have been approved also by US FDA and also by the UK FDA. So these are the two very, I hope I am giving you new knowledge with this, that about Uniject. Of course, the mechanism of action is it suppresses the ovulation, thickens the cervical mucus, thins the endometrial lining. Now, are there any eligibility criteria for using injectable? There are certain eligibility criteria. One is the adolescent. If the adolescents are using, the age has to be more than 16 years. I'll tell you why. Then can be used by nellipara also. Obese also can use, thin also can use. So these are the advantages. Even smokers, like we do not advise the combined OC pills for smokers, but injectables, those containing progesterone, can be used. If used post delivery, you should wait for 6 weeks. Why, I'll tell you. And post a bottle immediately within the 7 days, the injectable can be advised. Advantages: convenience is one advantage. Those who have faith in injections, they find it is very suitable. No interference in sex. all the side effects of estrogen, which you have come to know yesterday, these are circumvented. Reduce menstrual flow, so those who are having excessive bleeding, they find it suitable. Reduces and prevents anemia. Lactating women also very good use, because there is no reduction in milk volume. The constitution of milk is also not changed. However, it should not be given within the 6 weeks. Why? The answer is, as it may cause irregular bleeding pattern postpartum, and we are not accepting that irregular bleeding pattern, because initial postpartum we want to be sure that the uterus is empty, there are no tissues left behind. So you do not start within the 6 weeks of the postpartum period. Risk of ectopic pregnancy is slightly lower. Risk of endometrial cancer is much reduced, as much as 80%. So if the long-term use of injectable progesterones is there, then 80% reduction in the, so that's considered as a huge benefit, and women with endometriosis get huge symptomatic relief with these injectables, and that is considered as a great advantage of injectable. Apart from that, there are other certain benefits which are very typical, and these are the clear benefits. And specifically in sickle cell disease patients, in various trials conducted, women with sickle cell using DMPA have significantly few crises as compared to placebos. Anemia is reduced. The hemoglobin concentration rises. Why? Basically because the menstrual loss is low, and risk of endometrial cancer is 1/5 lower as compared to the uh, placebos, and it protects against PID, it protects against seizure in women with epilepsy. So you can see the advantages of uh, injectables. You're not advising your COCs in epilepsy patient, but you can use the injectables. It is very good in case of myomas and endometriosis. So accompanying gynecological disorders, if are there, then the injectable are considered as the contraceptive of choice. So if you are given certain special situations, then the injectables are considered. Now certain disadvantages are also there. There is a reduction in bone mineral density because the estrogen is not there. Irregular bleeding patterns are there. Some women may have heavy menstrual bleeding. Amenorrhea if there is prolonged use. Mood swings, depression, these are all associated with progesterone. Weight gain, I have already talked about 1 to 3 kg in weight, and delay in return to fertility. Now, a question which may be posed to you, is there, is infertility common in these women? No, it is only the fertility returns after a period of 9 to 10 months. So even if the withdrawal of the contraception is there, still the fertility takes a long time to come back, because the ovulation which is there, it takes certain time period to return back. So this is one of the disadvantage, if they have to wait for a 9 to 10 months period. So if they are planning a pregnancy, then the stoppage has to be that prior 9 to 10 months has to be taken into consideration. Effectiveness, as I said, very high. Failure rate is only 0.1 to 0.6%. Now, question may be asked to you, what is the effect on fetal exposure? Somebody had asked me this question for nonoxynol. For fetal exposure, no known adverse side effects of fetal exposure to injectable in the various studies conducted, and long-term studies have also been conducted, and studies on teenage children who were exposed to DMPA, there is no significant difference in health, growth, or sexual development. Okay, progesterone only injectable, however, should be used only after 6 weeks postpartum without adverse effect on the nursing mother. Next question to you use is, next question is there any effect on the metabolism? Like we have talked in the OC pills, you may have heard yesterday, the only metabolic effect of clinical importance is the weight gain. Okay, minor alterations in the lipid metabolism, the fluid and the nitrogen balance, in the steroid metabolism, in the glucose tolerance. So those who are having long-term diabetes mellitus, uncontrolled diabetes mellitus, are not advised to use the injectable. When you are talking of any of these effects, remember that DMPA has been more studies as compared to NET-N. So few data is available for NET-N as compared to DMPA. Any cardiovascular effect? Insufficient data is available for cardiovascular complication. However, WHO is saying that little or no increased risk of cardiovascular disease has been seen with progesterone only injectable. However, those women are having increased risk of high blood pressure, so very high blood pressure, you should avoid injectables. Return of fertility, as I have said, fertility is not impaired. So answer to that is no impaired fertility, but delayed return is there. More than 80% of women become pregnant within 1 year and 90% within 2 years. However, the data as compared to NET-N is less as compared to DMPA. Now, when you talk of eligibility, you should always remember that WHO has divided the eligibility criteria into 4 categories. Category 1 says no restriction for use. Category 2 says advantages are more as compared to the risk. Category 3 says that proven risks are there. So you have to be very careful when you're talking of category 3, and category 4 says unacceptable risks. So if somebody puts to you the question about eligibility, you should always talk of the category risks. Okay, so for your injectable, category 4, that is should avoid in case of pregnancy and should avoid if there is a malignant disease of the breast. No use of injectable contraceptives. Category 3 is diabetes with vascular disease of more than 20 years duration, cerebrovascular events or disease accompanying, then acute liver disease like hepatitis, which is ongoing, we should avoid, benign or malignant liver tumors, avoid severe hypertension. So mild hypertension can use, but severe hypertension where blood pressure is more than 110 to avoid, vascular disease with hypertension to avoid, already having migraine to avoid because progesterone will lead to headaches. It is known to associated, and severe cirrhosis also. So this is considered as category 3. Now category 2, where the benefits are more as compared to this, risks are mild hypertension, diabetes without vascular complications, and mild compensated sort of cirrhosis, you could advise with good monitoring. So good monitoring and screening of the patients is beneficial in case of progesterone only. But however, we do not use the combined ones in these categories. Now, certain special situations may be asked to you, questions may be put to you, certain special situations. What are these? Adolescent. Would you advise injectable in adolescents? Question is to you. I've already given the answer. They have a very important benefits in adolescents because adolescents are known not to use the OCPL well, not to use the barrier well. Okay, so in countries where even in India, we should promote injectables. However, avoid starting injectable for an adolescent less than 16 years of age because of hypoestrogenic side effects. One of the very important side effects to remember is decrease in the bone mineral density. So it should not be started before 16 years of age. What about women over 35 years? Can you give an injectable contraceptive? Now, the progesterone only and the combined ones can be used very well by healthy women. Remember the word healthy. If there is no associated severe hypertension or chronic diabetes, very well can be used. And if there is a cardiovascular disease, and can be used, but the woman should not be a chronic smoker. Okay, So you have to screen and then you can very well start. What about postpartum? Already answered this question. It is recommended, but of course, no negative influence on the duration of lactation or on the infant, but should be started after 6 weeks. Now, those women who are non-breastfeeding, to avoid increasing the risk of thromboembolic phenomena, do not start the combined one, but for the combined one, wait for 21 days, and after 21 days, the combined ones would be started. Now, another very important question which is asked with injectable is, what about drug interaction? If the patient is on certain drugs, is the efficacy reduced? Remember, few drugs, very important now, in the antibiotic, remember rifampicin. If the patient is on antituberculous drug, rifampicin reduces the efficacy. So, failure rate will increase. Griseofulvin, if the patient is on this, griseofulvin, if the patient is epileptic and on phenytoin, carbamazepine, if the patient is on barbiturate, then the efficacy is lessened, and hence remember this when you are advising these injectable to women. Now, what about a patient is on injectable and she has to undergo certain elective surgery? What to do? What is the advice? What the user or the provider should do? Now, it is advisable to stop a combined injectable contraceptive 4 weeks prior to surgery, because it will affect the coagulability. It will if the surgery involves prolonged immobilization, then 4 weeks prior you have to stop, and you can start after 2 weeks once the woman returns to ambulation. Then you could start within 2 weeks. Alternative contraception have to be provided if you're stopping, okay. And if it's an emergency procedure, then if you stop, then you have to consider giving a prophylactic anticoagulant measure, because thrombosis will be increased. Now I have highlighted to you that DMPA is a aqueous suspension, whereas NETN is oil based. So why did I highlight that? Because when you are giving the DMPA, you should shake the vial very vigorously before loading it to resuspend the active ingredient, which settles down at the bottom of the vial. If you do not shake well, then that active ingredient remains in the vial, and you need to check the syringe well to ensure that the correct dosage has been given. So this is why you have to remember that DMPA is a suspension. It has to be shaken well, whereas NET-N is oil based, and it needs special care to ensure that all the solution is loaded without leakage. And how do you do that? You warm the vial to body temperature, making it easier to draw in the syringe. So Naten and Mesigna both are oil based, and thus they have to be warmed before pulling it into the syringe, whereas the DMP has to be shaken well. These are certain practical tips which may be asked to you. Next question is, when can the initial first injection, when to start it? Now for DMPA, which is the progesterone only, you need to start within first 7 days of the menstrual cycle, can be started immediately after an abortion. At any other time you want to start it, rule out pregnancy, and postpartum 6 weeks have to be started. But if you compare with the combined one, it has to be started within the first 5 days, and of course immediately after an abortion, after ruling out the pregnancy, and 6 weeks postpartum. Very important question to you is for the next injection. Now I'm dealing most of the time with rural patients, and they will not come back to you for the next injection. So the high failure rate may be associated. So is there a margin or duration for which we can wait before giving the re-injection? Now that's an important question for the follow-up. With the DMPA, you can wait for 2 weeks period, almost 14 days before you can wait, if she doesn't come to you within the 3 months time. But for combined, she has to come within the next 3 days itself. So it's important to note that for combined CICs, otherwise there is a high failure rate. And because the follicles will be started recruiting within the 3 days itself, and you have to give the injection within the 3 days itself. Now for completeness, I will talk about vaginal rings and I will talk about transdermal patch, but not in too much detail. Just to complete the topic of non-oral hormonals, we'll talk about the vaginal ring. There are two varieties again of ring. One is the combined and one other is the progesterone only. For combined, remember the numerical 12. So it is 12 microgram of EE and 12 microgram of desogestrel. This is the content. It has to be inserted for 21 days, removed for 7 days and reinserted. So same ring can be used for 3 months. Remember that. Okay. But it has to be removed for 7 days when they are using a combined ring. Combined means both estrogen and progesterone is there. Whereas in case of progesterone only, which is a levonorgestrel ring, it contains 5 milligram with a daily release of 20 microgram. Remember that progesterone only ring can be used continuously for 3 months. What we learned in the prior slide, estrogen and progesterone combination, you have to remove every 21 days, give us 7 days gap. Okay, whereas the progesterone win only can be used for a prolonged period, that is 3 months. Drawbacks, it can be expelled and failure rate is 3.7%. So little bit higher, but many women prefer to use the vaginal ring, though not at all common in India. However, in European countries, in Nordic countries, it is considered as a very good, acceptable method of contraception. Another very good and preferred by women is a transdermal contraceptive patch, which is a sticky patch which releases the hormones. Again, this is the lower dose is required for a patch because the first pass hepatic metabolism is circumvented. Releases 150 microgram of progesterone, 20 micrograms of ethinyl estradiol. Duration of use is 7 days. Failure rate is very low, 0.7 per 100 women years. So very good transdermal patch. Remember that it is a weekly application for 3 weeks. So every 7 days, the patch has to be changed. Because the patch is seen on the arm or whatever body part the user is applying it, so it assures her that there is a continuous protection, no need for any vaginal insertion, and it is reversible, and excellent cycle control is there with the transdermal patch. The disadvantage is, of course, the cost and the availability. Feasibility is very good, but cost and availability is. You can see from the picture that first patch has to be inserted for 7 days, second pass from 8 to 14 days, third from 15 to 21 days, and there has to be a patch-free interval of 7 days. You can see here various body parts which it can be applied to: abdomen, upper outer arm, torso, and thigh, that is buttocks, where it can be applied. Very good and effective sort of contraception, which is the transdermal patch. Adverse effects of these patches and rings are all about progesterone, whatever we have learned prior. So there may be the application. In addition, there is an application site reaction, like you can see redness, breast discomfort, engorgement, and pain can be seen. Of course, all these are associated with progesterone. Headaches, emotional lability, spotting, and breakthrough bleeding, as common with injectable. Same type of things can be seen with the. So that is about the adverse effect. Now, ultimately, I will like to summarize by this one slide, and this one slide is for both the barriers as whatever I have taught you today. Try to remember the key points. What are the key highlights of what you are reading? revise it, discuss it, repeat it. You can see if you discuss 50% more retention. If you teach another person, 90% retention is there. So try to find out a colleague to which you can talk about it, and you would very well remember. It's not very difficult topic, but however, repeatability has to be there. That is all from my side. I can take any questions now. Thank you.
Sureka, thank you so much. This is Dr. Kedar Gandla.
Yes, Dr. Kedar, thank you.
Thank you very much for coming aboard and taking this lecture. I want to tell all the students that 2-3 days ago I had put a remark in the PG group that all of your cameras are closed. This is not done. We have a serious doubt that all of you are putting the cameras off and you're not attending, and then you are just collecting the recordings, which is not the way that teaching should happen. Has everybody understood? Has everybody understood what I'm saying?
Yes, sir.
No, Minal, from tomorrow 9 o'clock I'll be there. If
Yes.
the video cameras are not on, I will not allow any single lecture to happen tomorrow onwards.
Yes, sir.
Not a single lecture. This is not a joke. Everybody is taking so much of effort to teach you, and you are just collecting recordings. This is not done. You are sending our recording to somebody else. This is not done. I'm telling you, this is not done again. I'm telling you, tomorrow onwards, I will shut the program out.
Yes, sir.
Thank you. Take the question and answers with Madam, please.
Yes, sir. Sure, sir. Thank you, sir. Ma'am.
So Kedar has.
Ma'am?
Okay. Yes, please go ahead.
Yes, ma'am. Yes. Should the dose be adjusted if patient is on the above enumerated drugs? This was for the DMPA, ma'am, when there are the chances of drug-to-drug interaction like rifampicin and glycerin if patient is taking that. So need to readjust the dose.
So now see, efficacy is reduced, as I said, okay, but not to that extent that it requires a dose adjustment. Okay, you need to be very careful about what somebody is speaking in between and I am not able to speak. So dose adjustment. So if the patient is on griseofulvin and rifampicin, then the efficacy is little bit low. But as such, with the injectable, the efficacy is quite high. So instead of changing it over, you have to just monitor the patient and supervise the patient. That is my recommendation.
Yes, ma'am. And what about the patches? If they are if they are hampered with the sweating or bathing?
Yes, these may be the problem, and that is where those patients who are having. So that is why it is not so commonly used in countries like India, where the sweating is quite common, and that is why in countries like European countries it is more commonly preferred. Sometimes it may come off, and if it comes off and falls off without knowing, then of course the efficacy is totally gone, and an alternative method of contraception has to be used. So very carefully the woman has to monitor whether the patch has stuck to her body well or not. It is a very good adhesive which is being used, but she has to monitor that it doesn't fall off.
Yes, ma'am. Why 6 weeks postpartum gap for DMPA? Can we give it immediately after postpartum, especially in situations?
Now I have already answered that. I have already answered that question. Is because these injectables are associated with breakthrough bleeding and irregular bleeding pattern. Okay, so if you start immediately, okay, after postpartum period, now you are concerned of when the patient is postpartum, certain complications like retained weights, certain complications like the secondary hemorrhage you are concerned with. If there is an alternation in the bleeding pattern associated with progesterone, you're not able to diagnose those complications. So basically you need to give a 6 weeks gap, and after that you could start and very well go ahead. It is not related to the milk production, because as I've already told you, progesterone doesn't affect the quantity or the quality or the constitution of milk. It only affects the bleeding pattern. That is where we are concerned about in the postpartum period.
Yes, ma'am. DMPA amenorrhea treatment.
Now, amenorrhea treatment for DMPA. Basically, counseling is very important. For prolonged users, amenorrhea, some people enjoy. Some women will be very happy with the amenorrhea, and it is showing you that it is effective. But if they are concerned, and then of course with prolonged use, amenorrhea is going to be there, or even the reduced menstrual loss is going to be there. You just need to counsel and just need to assure that there is no pregnancy, and that the counseling is very very important part. However, the treatment is not there. I mean, you don't want to withdraw the contraception. It's a very good effective contraception, so you need to just counsel. You cannot withdraw and allow the menses to occur. Assure the patient that this is going to happen, and the acceptability and the continuation will improve for the users.
Ma'am, if breakthrough bleeding is a reason to start POP after 6 weeks, then in non-breastfeeding, why after 21 days it is recommended?
I already answered that, I think.
Okay, ma'am.
Yes, because of breakthrough bleeding, there is a disturbance in the irregular bleeding pattern, and you may not be able to diagnose certain postpartum conditions which are important to diagnose: secondary hemorrhage, retained tissues, the infection, the endometritis. You may not be able to diagnose if there is a irregular bleeding pattern, and that is why you need to give certain period of time and then go ahead and start.
How to treat irregular bleeding patterns with use of DMPA? We have taken that.
Now, even rural patients come with these questions. You can start simple drugs. So first drug which you ever start in any kind of bleeding is your non-steroidal anti-inflammatory and tranexamic acid. With tranexamic acid use, you can very well control that small amount of spotting or withdrawal bleeding which is there. No need of giving any hormonal injection or anything. The bleeding is very small and sort of spotting only. Assure the patient, and if she is very much concerned about the pregnancy, if it is there or not, you may try to rule out that. Otherwise, simple your NSAIDs are what are effective.
Yes, ma'am. There was one question. So why there is the irregular bleeding patterns with the DMPA?
Very easy to answer that. What is the mode of action? Yes, you have to, for this answer, you should know the physiology of menstruation well. If you withdraw the progesterone, if there is because the daily release is there, if that release of progesterone is not well and there is withdrawal of progesterone, then there is a irregular bleeding. So if that particular amount of progesterone is not available to that particular day, then there is a bleeding. And mostly the irregular bleeding may be seen in women who are prone to this kind of, if the age is more, you may see the irregular bleeding pattern. So it's a pathophysiology behind the usage.
Ma'am, why there is reduced sickling in sickle cell anemia with DMPA? Also, how seizure frequency?
There is a protective. There's a protective effect of progesterone, which has been known, has been studied, and that's why we are advising injectables very frequently to those women who are having sickle cell disease, the crisis. So if this is more seen in progesterone only type of injectables, and it is very well noted by researchers that it prevents the sickling. Okay, the pattern of sickling, it reduces, and hence crisis is also less.
Yes, ma'am. Most of the questions are done with the chat. So, thank you so much for your
Thank
valuable
you so
time,
much.
ma'am. It was a truly mesmerizing session, ma'am. Thank you so much.
So
We're
honor
very
for
lucky
me
to have
also.
you.
Thank you so much.
Yes, ma'am. Thank you, ma'am.
Thank you so much.
Yes, ma'am.